All right. Hi, class. This is Dr. Shahada, and in this video, I'll be covering Chapter 14, titled The Future of Health Services Delivery. All right. So in this week's module, you will have the PowerPoint presentation, which I'll be going over a number of slides in the presentation in this video, as well as a file that includes the terms and definitions presented in Chapter 14. All right, so I'm going to begin by speaking about the forces of change. So these are the 8 main forces that will help us understand why certain changes have occurred in the past, and they can help also inform the direction of change that might occur in the future. Now I'm going to switch over to the slides from the PowerPoint presentation on Chapter 14, and I'll be covering the 8 forces of change from the PowerPoint presentation. All right, so here is the list of the 8 forces of change. Now, the first one listed is social and demographic forces. These are factors such as demographic shifts, cultural factors, and lifestyles that will affect both the demand for services and the supply of a qualified workforce. So an example of this would be a growing number of elderly that will produce greater demand for chronic care and long-term services. Cultural barriers affect both the patient and the caregiver, and personal lifestyles will determine the future burden on the financing and delivery of healthcare. So here is the following slide, which covers social and demographic forces, as well as the following slide. So these cultural factors will create ongoing challenges. The next listed force is economic forces. So the national debt, economic growth, employment, household incomes will determine the availability of healthcare services, their cost, and availability. A lot remains unknown about the future economic impact of healthcare spending. It is expected to consume almost 20% of the gross domestic product by 2022. All right, and this continues the economic forces, and now we're going to jump to political forces. So health policy affects numerous areas in healthcare delivery, such as access to healthcare, particularly by vulnerable groups. Health policy also affects availability of services and healthcare professionals. For example, policies that affect education at home, as well as immigration policies, can determine not only the number, but also the qualifications needed for the future healthcare workforce. The next force of change is technological forces. So technologies will promote a greater degree of self-reliance and also achieve cost efficiencies in certain areas of healthcare. However, the overall effect of technology is to increase costs unless it is accompanied by utilization control measures. So the increasing of the costs of healthcare costs is one of the factors, as well as promoting innovation of medicine. I touched on the topic of self-reliance and utilization control measures. Now, the following slide talks about the informational forces. So the application of IT, or information technology, in healthcare is still evolving. It will continue to impact healthcare delivery and management of healthcare organizations. Now, ecological forces is another force of change. New diseases, natural disasters, and bioterrorism have major implications for healthcare delivery. These forces have global consequences, requiring international cooperation and sharing of resources. Now, the next force of change I will cover is on the global forces. So health and healthcare in various countries will continue to be affected in diverse ways through multiple pathways. Manufacture of generic drugs, medical tourism, international medical missionary work, and cross-border telemedicine will grow, but they also face barriers. Now, an example of this cross-cultural factors that affect this effectiveness of professionals include brain drains or brain gains. Now, the next slide is a video on America's brain drain. What's been happening here in the US is we used to have this brain gain. So people were coming from other countries, specifically researchers, to do their research here. Now, since around 2014, this trend has actually reversed. And a lot of it has to do with how competitive it is to be a researcher. And so what's happening is the last 2 years, there's been a lot of researchers that have been offered jobs abroad to conduct their research and provided funding. And this is where this reverse effect is occurring, and we're going through a brain drain. I actually have at least 3 of my colleagues that, not here at FAU, but friends that also have doctoral degrees and focus on doing research, that have left the country. And I have one friend that's in Kuwait, and my friends that are social scientists or social behavioral researchers. And in the last 2 years, they have left the US, born and raised here, because they were offered great positions outside of the country. So it's interesting that the opposite is occurring at the moment. Now, the last force of change that I would like to cover is anthrocultural factors. So we're looking at American beliefs and values that have historically opposed radical changes in healthcare. So historically, these have acted as a strong deterrent to radical change, right? So that disapproval of the Affordable Care Act has increased among Americans, and the American public may end up deciding that the Affordable Care Act isn't working. We are not sure what the future holds, but it is definitely a possibility. All right, so here we are at slide number 18. Now, will the U.S. have a single payer system in the future? Much will depend on the Affordable Care Act successes, failures. It will be interesting to see what the future holds. Now, the Affordable Care Act was based on 2 major historical state-based initiatives. It was based on the Oregon Health Plan and the Massachusetts Health Plan. So a little about the Oregon Health Plan. In the 1980s, the plan was formulated over several years, and it had 3 main components. The first one was a Medicaid expansion plan, enrollment in managed care, and rationing of medical services using a priority list of condition treatment pairs. There was also state funding to offer health insurance to those with pre-existing medical conditions, and the employer mandate. So the Oregon plan required employers to provide medical insurance to all employees working 17.5 hours or more. All right, so for the Massachusetts Health Plan, first, there was an individual mandate. All residents must have health insurance. There was an employer mandate. So all employers with more than 10 workers needed to offer health insurance. Premium subsidies for low-income people, so those with 300% of the federal poverty level pay a subsidized amount. And there was a central connector that facilitates purchase of health insurance. Only approved plans can be sold, similar to the exchange we see with the Affordable Care Act. Now, the Massachusetts plan has achieved some successes, but cost remains the main issue. Remarkable increase in insurance coverage. 62% have employer-based coverage. And in the connector exchange, premium increases surpass inflation. So the state had to set limits on the rise in premiums. So what was the primary lessons here? Well, regarding Massachusetts, although there was a major improvement in reducing the number of uninsured, cost containment has remained a major challenge. Despite general satisfaction among the insured, some issues with access and disparities also remain unaddressed. All right, so now I'm going to jump to slide number 26 and just briefly discuss the likely experiences under the Affordable Care Act. So we have this caveat where one state does not represent the ethos of the entire country. Unlike Massachusetts, a significant number of Americans and physicians in particular have been against the Affordable Care Act. So we have this high level of dissatisfaction among physicians. Access to healthcare would likely be an issue in the future. So mirroring the experience in Massachusetts, the Affordable Care Act also has this greater government control over healthcare through stifling regulations, lower reimbursement for providers, higher costs, and higher taxes. Now, the possibility of repealing the Affordable Care Act could happen. I mean, I believe it's unlikely, but it is definitely possible. As happened with, it has happened with the Medicare Catastrophic Coverage Act of 1988. So the seeds for healthcare reform have already been sown, and it will no longer remain a dead issue. Any future reforms would build on rather than scrape completely some of the provisions in the Affordable Care Act. So it's probably going to build on what's already there. All right, so the next couple of slides still covering the same thing. Again, there's this just decreased level of uninsured among vulnerable populations, which is great. There is still a significant population that is still uninsured. And again, we've spoken about the shortage of primary care physicians. Also, Massachusetts experience suggests lower reimbursement, higher costs, and higher taxes. There are small businesses that expect negative effects. Negative sentiments could lead to, again, as I touched before, a repeal of the Affordable Care Act's major provisions, but we don't know what the future holds. So now looking at the delivery infrastructure of the future. The healthcare infrastructure will continue to evolve by incorporating high-value healthcare, lowered costs, and improved quality and patient engagement. One model will not suffice to meet a variety of needs. Emphasis on evidence-based care will definitely be a focus as well. Cost-saving technology, targeted programs to the needs of patients in the community, training of practitioners for wellness-oriented model, and remote monitoring and virtual consultation. So these are the areas that will be continue to evolve in our healthcare delivery system. Now I'm going to touch on the medical home model. So there are new models of care delivery. Now, one of them being the medical home model. The aim is to be built on a foundation of accessibility, continuity, coordination, and comprehensiveness. Mechanisms for matching patients to homes. So the idea is transparency and fairness, matching of clinical needs, predictable revenues for the physician, and the exchange of information to support patients with varied and complex needs. Also reimbursement that captures critical non-clinical activities, such as care coordination. Now, the next slide, I will be covering the requirements for a community-oriented primary care model. So the focus on primary care will require training of physicians. Social and behavioral sciences should supplement the biomedical model. Primary care should include primary, secondary, and tertiary prevention, and public health functions must be strengthened. Now, the next slide covers the Vermont Blueprint, which has successfully integrated the two models I just covered. And community health teams are employed for individual care, coordination, health and wellness coaching, and behavioral health counseling. So again, in 2006, Vermont launched a program called the Vermont Blueprint for Health. And it was based on a foundation of both models that I covered of the medical homes supported by community health teams. Each community health team is staffed by 5 full-time equivalent employees and led by a registered nurse to serve a population of approximately 20,000. Now, lessons from the Vermont Blueprint model. Integration of medical home again and the community-oriented primary care models. Community health teams were responsible for a defined population, and reduced emergency department use and hospitalizations are necessary for financial viability. Now, the next slide covers the role of patient activation. So patient activation refers to a person's ability to manage his or her own health and utilization of health care. Activation faces 2 main challenges. So the first challenge is patient's own mindset greatly influences utilization decisions. Often, patients doubt and question the judgment of primary care physicians, which can affect how they manage their own health. The second main challenge is the activation levels differ considerably across socioeconomic and health status characteristics. Closing of such gaps would require information and support. All right, so next I will be going to the slide covering future workforce challenges. We're right here, which is slide number 42. Now, the 4 main recommendations that have been put forth regarding the nursing profession. The first one is uniformity in the scope of practice for advanced practice nurses. So this has been impeded by varying licensing and practice rules across states. Residency programs should include community settings. Second, higher levels of education and training are necessary to handle increased clinical demands and to build competencies to deliver high quality care. Nurses should also master technological tools and information management systems. Partnership with physicians and other professionals by taking responsibility for identifying problems and areas of waste, developing improvement plans, tracking improvement over time, and making necessary adjustments. Better data and improved information systems to improve planning and policy making. Now, the next slide. So the next slide, or this slide, I'm actually here already, I'll be covering the training that's needed for primary care physicians to become comprehensivists. All right. So comprehensivists will need training in the following areas: anticipating, preventing, and managing common complex conditions, managing complex pharmacology, understanding end-of-life issues and medical ethics, coordination of care, and leading healthcare teams. Now, the next slide, I'll be covering some of the main reasons behind the deficits in geriatric training. And then I think I will be wrapping it up. And again, you are expected to read the chapter and go through the full PowerPoint presentation. So let's talk about some of the main reasons behind the deficits that are in geriatric training. All right, so there's a shortage of faculty in colleges and universities who are trained in geriatrics. Only 600 medical school faculty out of 100,000 list geriatrics as their primary specialty. 60% of nursing schools have no geriatric faculty, which is very interesting. Only 3% of medical students take any elective geriatric courses. In other disciplines, such as nursing, pharmacy, medicine, and dentistry, the majority of educational curricula do not require geriatric training. All right, so the last topic I'm going to touch on are the 6 main areas of concern that need to be addressed regarding the future of long-term care. So baby boomers will start needing long-term care in 2025. Now, regarding the 6 main areas of concern, first, regarding financing, private long-term care insurance will be critical to relieve public burden. Competing policies need to be comparable, and premium costs need to become more affordable. Regarding resources, eligibility for community-based public programs has been relaxed under the HCBS waivers. However, Medicaid spending has continued to increase as more people may be induced to enter the Medicaid program. Regarding the infrastructure, so new models of institutional care are emerging. New architectural designs, living arrangements, and worker and patient empowerment are improving the quality of life in nursing facilities that have adopted cultural change. Okay. Now, regarding the workforce, which is on the next page, there's a shortage of workers in the long-term care workforce, and it's expected, this deficit is expected to increase. Now, regarding regulation, so there's contradiction between certification regulations and internal quality improvement programs. Also, regulations are inconsistently applied. All right. And regarding information technology, being able to use and exchange information technology systems are needed. Now, I'm going to jump back to the information from the chapter section in this week's module, and we'll be wrapping up this lecture. All right, so here we are. We pretty much covered most of the topics that are listed here. Make sure to read through them, address them in the chapter, review your PowerPoint presentation, and if you have any questions, do not hesitate to let me know. And that pretty much covers chapter 14. Take care, everyone. Bye.